while these agents have provided us a lot of success, I think there's a lot of room for improvement with these agents, namely trying to identify patients who are going to most likely benefit from these agents, but also try to find out the least toxic way to administer these drugs. So starting with the first, trying to identify the correct patients. Lots of people are looking at both biomarkers from a biological perspective, such as tumor biopsies, blood samples, DNA mutations and such, and I think those will all be helpful. One, of course, being PD-L1 status, whereas it's not a perfect marker, it does seem to associate with benefit to single-agent anti-PD-1 therapies. But what's interesting is that the PD-L1 negative patients can also benefit from these drugs, although not at as high of a rate as a PD-L1 positive. However, in the combination studies with using ipilimumab and anti-PD-1 agent nivolumab, the PD-L1 negatives seem to respond at a similar rate, which suggests that perhaps in the future, this might be, even the negative marker might be a good way to pick patients to get what's considered to be probably a more effective but a more toxic regimen, which gets to the point of trying to decrease the toxicity for the patients, even though it's such a good time in melanoma that we're increasing the efficacy so great that now we get to talk about decreasing toxicities, and I think that's one way that we can think about doing it. Another way is some data that we looked at least retrospectively, showing that baseline tumor size is a very strong predictor not only of survival but also response to monotherapy anti-PD-1 pembrolizumab. So the question would remain, if some patient has very low burden of disease, would we be better off treating them with a single agent that has a very high response rate and very low toxicity, rather than subjecting them to combinatory therapies where, while the response rates might be higher or even better, but the toxicities certainly would be much higher than the single agents.